Well, welcome back. I hope you had a good but short break there. We'd now like to open the floor to discussion and questions, particularly anything that you heard from the panelists and the speakers this morning, but anything else, comments that you'd like to make in addition to questions. We'd first like to start with members of the Roundtable and the Planning Committee, but we'll quickly follow with others who have comments or questions too. So I'll start with one. I thought it was interesting as we listened to all of the presentations and thinking around some of the things that we need to do. But I also heard Janine say that they had sundowned some programs and activities. I find that's really hard to do once a program or service starts, to stop it. So Janine, could you just comment about that? You said you sundowned some things. How'd you do that?
Yes, absolutely. So thank you for the question. One of the things that I had shared is we take the position that to collaborate, you must give and you must take, and you have to have rewards, but you also have to have risks. So everyone working with us through our coalition has agreed that we're really taking a community-wide approach, and sometimes that means that there might be duplication of services for a particular service in a particular area serving similar individuals, and either aligning those or sundowning those programs might create a better community. So they have all committed to do that. And in fact, we have sundowned some programs because of those types of commitments and those types of leveraging across our community. Let me share with you one particular thing that sort of had led to some of this. The United Way is part of our initiative that we do. And our United Way has a commitment to health with a significant chest that goes to social service agencies, et cetera, focused on health. We now work with the United Way that for any request coming to them must map to what it is that we're doing, and it has to align and leverage resources to what it is that we're doing to receive United Way funding. That is also happening with our local foundations. So it's really looking from this expansive community position, and sometimes that means that resources come to an entity to ramp up services, and also it means sometimes resources are no longer available because they could be distributed or serviced a little differently, namely the sundowning of programs. So thank you for the question.
Thank you, Janine. So please say your name and where you're from.
I'm Jim Nickman from the New York State Health Foundation. So I'm interested in how you react to each other's presentation. It's interesting. I try to figure out, okay, in some ways they sound the same, in some ways they sound very different, and I'm wondering how they sound to you guys about, because the common thing is energy and activity and optimism. But I'm wondering if you see a lot of commonality or that you think what you're doing is very different from the person sitting next to you. And George, especially in California, do you see all the communities, and does the endowment see more commonality or more diversity in terms of strategy?
It's both, Jim. We see both optimism and pessimism. We see a lot of energy, and we see people holding back. We see those that we need to convince to come to the table, and others that are very eagerly at the table. And I think we're seeing that across the country in the red and blue states. We're seeing people that are running to the ACA to implement it, and others that are trying to repel participation in it. So in all of those, you have the spectrum of folks that are willing to cooperate. The interesting thing is that what brings people to the table isn't necessarily the same thing. In California, where ACA is being implemented, and it is the law of the land, and is being treated as such, there are those that are looking at the opportunity to make more money. There are opportunists, certainly there, and entrepreneurs that are coming in with their own ideas, even ones that we hadn't thought about how they might be able to capitalize on capturing patient populations they hadn't had before, expanding their service panels, being even more engaged, possibly even around population health, where it can be make money, like social impact bonds, as it was brought up as one. And then there are those that are looking at expanding their base of power, their power bases. And some of these are the same systems that have been there for some time. Primary care physicians or physician groups, specialty physicians that are insisting they need more of them. They need more doctors trained, medical schools, bringing new medical schools on board. Who would have thought? Because that isn't really part of what represents primary care or certainly population health. But all of a sudden there are people that are coming to the fore saying we need more medical schools to train more doctors, and we're thinking, well, do we need more doctors in Beverly Hills? Do we need more plastic surgeons? Or really, what do we need more nurse practitioners and medical assistants, expanded role medical assistants in particular? And in our parlance, what we're talking about in population health with the endowment is a lot more boots on the ground in the community, not people behind the walls in clinics, but people that are out there in the community, helping the community to reduce their risks, create much more resilience, be much more politically engaged, engaged as stewards of community health, personal health, school health, overseeing that the planning commissions are doing the right thing in terms of the environment and in terms of health, and creating a whole social movement toward health in all decision-making, or health in all policies, if you will. Those are the kinds of things that we think need to be populated with the residents of communities, and especially the youth. And this was another thing that's bringing to the table. We're seeing youth come in, which is really interesting. We haven't seen too many movements, especially a health movement, that attracts youth, but we're seeing a lot of junior college and high school students taking on school projects, making murals and slam poetry and videos with their iPhones and cell cameras, and doing a lot of innovative things about talking about health and about social movement in ways that maybe we haven't seen in a few generations, which is really, really refreshing.
Comments from the panelists on things that you saw across your presentation.
Well, I certainly saw a lot of common themes for sure, and that was reaffirming that at least we're all rowing in the right direction and on the right track. But I also saw that given the different organizations that we represent here and the different focus or angle that we are approaching this, I did see some opportunities, I think, certainly to be able to look at what each one is doing within those communities. And I didn't see anything that I didn't think that I could bring back to Hennepin County and replicate, but certainly I saw some opportunities for bringing more players to the table.
I'll just say that I think in public health, we've been driving people to think about outcome focus, and I think that is in a way what you saw here. I mean, there's a tipping point. People are trying to identify things that we think might work or have worked in pilots, and to see if we can take them to scale. Also think that, is there a proof of concept here? Are we really being rooted in the data? Because I think that even in our experience, looking at the hot spotters, if you will, or the high utilizers, some of the things that we saw were not intuitive. We know about some that are common, but not intuitive. So you have to get back to our public health practice, I think, of really being rooted in the data and that outcome focus. So I think that the commonality that we saw across here is every community has to understand what's going on in their own community and who their stakeholders are in that readiness. But that the commonality, I think, is that the work, agreement around the work that needs to be done to preserve population health, to keep make it sustainable. And to me, that's kind of like looking at the public health practice always being outcomes focused. You get to it differently because your epidemiology is going to be different in different communities, so your priorities will be different. But I think that what we demonstrated today from, one community in Minneapolis across the board was that that outcome focus and understanding what are the crucial elements need to be identified with leadership around how do we land this plane in our particular circumstances. So I heard a lot of that commonality, but at the same time, the need to be really specific about what's the problem you're trying to identify. Who are your hospital systems? Who are your payers? What's their culture, and how do you manage that to get the outcomes you want?
Yeah, I heard a lot of people mention the triple aim, and I think the triple aim has made it legitimate to talk about cost. And so almost all of you talked to either ROIs, payment models, incentives, cost avoidance, global budgets, reinvestment, which I think is a great way to put that in context with the health outcomes piece. Next.
Hi, I'm Emily Jones from the Office of the National Coordinator for HIT, formerly of HRSA, so I love the inclusion and frequent mention of federally qualified health centers. That's great. But in my current role, I'd love, obviously all of you kind of had themes of health information technology and exchange. So I'd just love to hear if you had any kind of suggestions for ONC and CMS as we're formulating meaningful use stage 3, any other issues you'd like to highlight, barriers. There are plenty of them, so we'd love to hear what you have to say on that.
I could jump in for a second. I have the opportunity, because I'm on the HIT Policy Advisory Committee, to talk about this a little bit, but in this, in this,
So he's your ringer.
It's so important to think about the environment in which HIT is embedded and whether the incentives are pointing HIT in the right direction, because it's really a tool, but you want to have it useful for what you're trying to do overall. So in Maryland, we have this health information exchange. One of the things that we do with it is we allow primary care doctors to upload their list of patients, and they can get secure messages immediately when their patient goes to the ER or it gets admitted. So that allows them to better coordinate care. You're not waiting for the fax the next morning. And we have 10,000 notifications going out a month right now. And there's just a lot of appreciation for that service. And there are others that are being developed. And it's all in the service as these new financial incentives come around to help medical homes, to help hospitals. Hospitals are some of the most active consumers of data from our HIE because they're interested in their readmissions, and now we can tell them exactly where they're going and who they are, and it allowed a huge amount of analysis by these hospitals on global budgets around this. So, I think that as, the EHR kind of transition happens, really thinking about how the systems work and produce health outcomes that are embedded in these systems that move forward. For us, it's at a state level, but it can also be at some of these other levels. It's important. I'll stop there. I apologize. Because of the storm, I have to get back to Baltimore. So I really appreciated the panel, and I thank everybody here for their work.
I'll just add, I think one of the things that I would ask you to make sure is it's really important, if we're going to address health equity, to have race and ethnicity data. And it's expensive to add code lines, and it's expensive to change practice, but that could make a big difference in us knowing where we need to focus, where we need to bring resources to bear, and which communities we need to listen to because our interventions aren't working.
We have quite a bit of discussion about the use of technology and information technology in sharing between public health for analytics and the healthcare delivery system, and I'm sure you've heard most of that, electronic health record, and even use of telemedicine for allowing remote diagnoses or remote care management, and using other health professionals, not just physicians and not only specialists for getting to more remote populations. But I'd like us to think about, and you asked for something new, and that's telepublic health, telepopulation health, using communication systems and telesystems for sharing among the health departments in places that are far remote from the urban centers that have the epidemiologic manpower and horsepower to drive a lot of deep analytics and have them benefit the remote areas as well, and consultations around legal aspects of public health, the human rights aspects of public health that could benefit more remote areas of the state or the less well-resourced public health entities. We're sharing for communications and public media utilization and sharing communication campaigns using health information and information technology and even technology in general, web-based technology and social media, for really being much more expansive about not only getting people to enroll and recognize the importance of taking on health insurance as a cost burden in your family that you've never had before, but what do you do about that insurance? What do you do with it? How do you use an emergency room? How do you use a healthcare provider to your best advantage? And what should you be doing for yourself and for your own family before you run to an emergency room or a hospital or wait until a condition gets so far along? And then not only that, what kinds of behaviors are at lower risk, and what kinds of things exist in your community that can help you to have healthier behaviors. Those are the kinds of uses of communication and technology that we're way underexploiting and could contribute mightily, not only to a longer-term cost, but to present-day costs in terms of how you use the system and how well you use the system and how it can benefit you, and you can get greater satisfaction as well as having the system itself benefit from people that are taking a much greater part in their self-management.
I think for us as a community health center, I mean, we're certainly one of the fortunate ones in that we're connected with the county. So we were early on in 2008, we were able to implement the EPIC system, which throughout Minnesota, most of the major, I shouldn't say most, all the major hospitals utilize, and so we were able to have that ability to share that data. But that's not the case with the other community health centers, because EPIC is a very expensive system, and so they then have systems where they don't have that ability to communicate. And so I think being able to have some system where there's the interoperability, so now we've got this number of fragmented EHRs, and they're useless unless they can communicate with the major health systems. And then talking about the analytics, being able to have trained people that can provide that service, we found that we couldn't find anybody. And even we were competing with hospitals and others, and even when we would find someone, they were like gone, and a lot of them went to California, so I think that's probably where they are. But what we found was that we had to start training our own people who just either had a gift for IT or really liked it, but there's still that void of how do you, because you've got the data, but then how do you then manage the data, and then how do you translate the data, and then how do you get that translation into the provider's hands, and then how do they then use that information to communicate it with the patients, and then how do you get the patients involved as well in terms of, I mean, with EPIC we have the MyChart, and so patients can go on, but even getting them into that, and how do we connect that even with social media. So there's a lot of groundwork that needs to be covered around that, and I just think that had we had a lot of that discussion on the front end, it may have prevented some of these issues that we're having now of how do we make this really truly meaningful use.
I'd like to add just a small point, sort of a takeoff of some of the things that the other panelists had said, is that if we're truly looking at population health, we typically are, like we are in Akron, looking across health systems as well as many other entities that are providing data. And some of that is operability issues about the infrastructure that we use or the software or the hardware we use, but we can't ignore the issues of human factors and also the issues of relationships and the issues of trust. And those sometimes are the ones that make things not be successful because they weren't addressed on the front end. So as we think about how do we do population health across very large, either geographic areas, institutional, diverse institutions, et cetera, those human factors issues and the way that we address those a priori can really lead to either challenges that can't be overcome downstream or successes that can come a little more easily.
Thank you. I'm going to take one question from the webinar listeners. It's coming in over our electronic systems here. And that one person has said that one of the things that they saw across the panelists was the abundance of community resources and how people were tapping into that. And the person's question was, how have you set community-wide goals or involved the community in doing that?
I can talk across Oregon. I mean, first of all, in our legislation, all our CCOs have to have a majority consumer advisory group on them. So, and they have very specific in the legislation tasks that the coordinated care organization has to report out on and be engaged in and take back to that community advisory committee. So that is one way that we did it. The other way that we did it, and I had some numbers about, we spent several years going across the state with a variety of ways. Community-based organizations participated and led a lot of the input sessions, as well as set the goals and identified what they thought the barriers were to health in their community. Because we're really trying to focus not just on care, but how do we get to health. And we know that a lot of people in our community don't have access to care, so that's a big barrier in achieving individual health as well as community health. So try to set that stage across the years of committee work that we did. We also have consumers and community-based organization requirements to participate in all the metrics committees, the outcome committees, as well as the governance of the coordinated care organizations. And I'll just say also, that includes the mental health authorities and the public health authorities. They have to sit in governance on the coordinated care organizations.
So within Northeastern Ohio, we have done what I would call traditional approaches, which is making sure that each and every is represented on our coalition regarding some of the initiatives that we do, making sure that initiatives that they're involved in are integral parts of what it is that we do. And of course, they have an equal seat, they have an equal vote. But we also have done things that I would consider a little bit different, a little bit perhaps innovative. One of the things that we have done is we put together what we call a soft leaders group, and we went out through the community using a capture-recapture method and said, who within your community would you consider to be one of the soft leaders? And what we mean by that is not somebody who's a leader by title, so it's not the minister at the local church, but it's the person who has their pulse on their neighborhood, their pulse on their community. And we have assembled them within a community engagement group that we work with, and that they're really one of our final checks before we do anything. These individuals are integral to what it is that we do because they're the ones that can help us through the broader community in terms of engagement, but also perhaps, and even more importantly, tell us where we might have not included something that definitely needed to be included. So these are those neighborhood, on-the-ground leaders that really have a pulse in their community that can help and/or help us overcome challenges as well as facilitate a lot of the initiatives on every level of that health impact pyramid.
Something that we've done at North Point, we've have patient listening groups, which I talked about, and we convene those groups quarterly. And they're done in different cultural, ethnic groups, and they're also done in different languages. And so that gives us real-time kind of ongoing feedback. And then what we do in terms of engaging the larger community, we have what we call a community listening project. It's a very expensive endeavor, but it's one that we're committed to doing every few years. And so what we've done is a little bit different than your typical focus groups, because if you just have a focus group, you tend to find that the same people tend to show up at those focus groups. So when we do community listening sessions, we go out to groups where people are already gathered or where they are already connected. And then we engage members from those groups to participate in the process. And it's a pretty broad process where we don't have a list of questions, but we have areas of focus. And we may only have one question, for example, and that would be, give us your vision for a healthier community. What does that look like? What are some of the things that are important to you? And then we publish that. We go back to those community groups and we say to them, this is what we think we heard you say, to have them validate that for us. And then that becomes a blueprint for us as we're moving forward in developing goals and making sure that we are on target for what the community has said. And then certainly being a community health center where majority of your board are members of the community and are patients of your health center does keep us focused on what the needs are and the goals of the community.
John?
Good morning. Great presentations. John Auerbach from Northeastern University. And when I got online, I was actually going to ask a question of my own, but I was handed another question that came from a participant in the webinar, so I'm going to read that question instead. This is from Dr. Jose Montero, who is the Commissioner of Public Health in New Hampshire and a leader in ASTHO, where he's focused a lot on the issue of population health and clinical care connection. So Dr. Montero says, several of the presenters, if not all, have mentioned mental health, drug abuse, and long-term care, and those are key drivers of service use, high cost, and clearly have an impact on population health. How can we successfully integrate those areas as part of accountable care organizations and the ACA expansion? And are there any models of payment reform in those areas that highlight primary prevention for behavioral health and long-term care?
Well, this is a journey, right? You know, so I'll just tell you where we're starting. In Oregon, first of all, behavioral health, addictions, mental health, dental health, physical health is all included in the global budget. So how different communities, the coordinated care organizations in the communities decide to spend those dollars happens with their governance structure, which includes public health and mental health authorities as well as consumers. So going fast forward to my point here is that we're expecting that the data that is provided in that community will drive the particular interventions. So there are a number of early interventions around mental health that have been proven. They're part of the community guide around particularly early interventions with adolescents. So we have had some pilot projects over the last couple of years, and we're looking to incorporate those as, you know, part of the continuum of care that's the regular source of care. That's one example. There's a SP, I forget what it's called, but it's an evidence-based practice for early intervention with mental health that demonstrates that you can, you know, really work to stop the progression, as well as all the public health environmental factors around domestic violence, around gang interventions, things like that, that really bring all those to the solution table, not as individual projects, but as a strategy for a particular area, region, jurisdiction in the state.
So we have done very much the same thing, both from the position of health promotion and disease prevention for mental and behavioral issues, as well as for access and delivery. We do that through a number of different sites and programs, but we also look across that spectrum to make sure that we're really tapping into social and emotional wellness on every single level. One of the other things that we've done over the last few years is 2 demonstration sites, and we've been working with the model of co-locating mental and behavioral health and physical health, but we've moved beyond that. So our 2 demonstration sites are really integrated practices where we're testing payment reform models for mental and behavioral health as well as physical health. And these have been successful. We have about 12 months and 18 months worth of data so far, so not out to the 3-year mark where we have for some of the others, but we really believe those integrated programs for the healthcare delivery holds a lot of promise for what we can do for that end of the spectrum. And then prevention programs or social and emotional wellness programs for the other ends.
Well, one of the things that we've done with Hennepin Health is in this second year, one of the goals is that for any of the patients that are being discharged because of a mental health diagnosis, that within 30 days they have to be connected with a community health provider. And so you talk about an incentive for the hospital and for really all of the partners to make sure that there's that connection, because what was happening before is, people would be getting discharged, there was no connection to any ongoing therapy or mental health provider, and then they were coming back. And so now with that as one of the main goals and one of the ways that the cost sharing happens is that indicator has to be met. What we've done at North Point for years now, we have already integrated our behavioral health with our primary care. So we have a behavioral health therapist that is embedded within the primary care. We found that most of our primary care patients were getting their mental health prescriptions from their primary care docs, and some of them were not being referred into behavioral health for therapy. And so a lot of that, having a psychologist embedded within the primary care has really helped that integration. The next level that we are moving to now is to have a shared treatment plan. We're already on the same system, and so now any patient that has both a mental health diagnosis and primary care provider, that treatment plan is merged. So the primary care doctor, when they're looking at their record, they're seeing the mental health treatment plan, and so that they're now working together and vice versa.
Since we're in Washington, D.C., I want to give a shout out to CMMI, who actually in their Healthcare Innovation Award Round 1 is funding a number of innovations to integrate mental health, behavioral health into primary care. ICSI has one of them, in which we're in 8 states doing an integrated model of screening for depression and substance abuse and treatment in primary care with a consultative psychiatrist. Since the person from ONC was here asking what we need, we have found in the 8 states, you have electronic health records, but you don't have registries within them that can help you do systematic case reviews to actually do this kind of care of this integration. So that's something we desperately need as a nation for that to be developed. And we're supposed to, as part of it's called Compass, part of our model, propose a payment model back to CMMI that could be used for Medicare and Medicaid. That's one of our deliverables. So I know the federal government is working hard to address these integrated models and to help build them with that.
I just want the community health centers in Minnesota would be really mad if I didn't. We just got in Minnesota the legislature that approved legislation for same-day medical and behavioral health visits. So previous to that, federally qualified health centers were not able to get reimbursed for medical assistance patients if they were to see a primary care doctor and a mental health provider on the same day. And so the legislature saw that this truly was not the direction that we were going, so they did pass that legislation. And so effective, I believe this fall, we will be able to start doing that. So that was major for us.
Judy?
And since you brought up CMMI, I want to thank CMMI for letting us get a waiver to use some of our CMMI dollars for housing, because, I mean, it's sort of like those of us who have been in public health for a long time understand the concept of housing first, but it's really helped us stabilize get in the direction of stabilizing the people that we do identify that have these coexisting disorders.
Judy?
So, good morning, Judy Monroe, CDC, and a member of the Roundtable. I oversee an office at CDC that supports health departments across the nation. So this question is really for Stella. I think others may weigh in. But at the end of your presentation, you mentioned an initiative with the health department, but I didn't hear the health department in other parts of your presentation. So I'm curious about, as an FQHC, your relationship with the health department, and do you see opportunities where health departments could play a better or different role with all the changes taking place?
Definitely. So because we are in the city of Minneapolis, we have a role with the health department with Minneapolis. So Minneapolis has their own health department, and then Hennepin County has their own public health department. And if you saw that the public health department was part of the ACO, so they're one of the partners. And just recently, what Hennepin County has done was that it has put all of their health departments or health entities into one health business line. And it took a while, but for the county to recognize that they are in the health business. For the hospital, which is, even though they have spun off from the county, Hennepin County is responsible for their uncompensated care, and they are also responsible for a number of their capital projects. So within the health business line, we have the hospital, we have the public health department, and the social services piece of that, and then North Point as the FQHC, and then we also have the medical examiner's office as well, which is something that is very unique. Minnesota is one of the few states where the medical examiner is a physician and is also a forensic pathologist, and so the opportunity to align all of those departments around getting better health outcomes for Hennepin County is really significant.
We work quite a bit with health departments in California, and as a funder and as a system supporter. And in our discussions and in our programs, and community transformation grants being one, we find that they run the spectrum. Some are really spot on with regard to health equity and community collaboration. But many of them, and by and large, I'd have to say, health departments do not understand the depth of commitment in terms of power sharing with communities and in terms of truly doing population health programs, because they continually recede because of the shortage of resources to this communicable disease command and control structure, doing only the mandated services in many of their areas. And that's truly unfortunate, because if there's an entity that would be available and probably positioned to sustain the work of population health within the Affordable Care Act, it would be health departments. They're in every jurisdiction. They have the authority in law and the mission to do that. But they just, in too many places, don't have the leadership or the orientation, and certainly not the resources to carry that out. And their political leaders, unfortunately, and in some areas even prevent that from being done because of the concern about cost and this idea that should they be responsible for doing everything that has to do with health, or just the few things that they're funded for by the Centers for Disease Control or by the state or the county in some cases to do. So truly, if we want them to be part of the ACA and to do much better population health, there's going to need to be capacity building and resourcing to that effect. And one of the biggest, I think, opportunities lost, and continually so, is how categorical funds have restrictions, so that health departments cannot use those flexibly for moving into population health broadly to aim at the things that are the most attuned to the community needs and the biggest community problems, which by and large are going to be chronic diseases, but instead are focused narrowly on tuberculosis control, or on sexually transmitted diseases, or on public health laboratory services. and not on the bigger picture items. So the more you can do about that from the Centers for Disease Control, the better.
I would like to add something. The Summit County Public Health is a key partner of what it is that we do, and given our partnership, now they're able to move to population health in addition to the key services, so much so that they had applied for accreditation based on our relationship in public health, and they were just awarded it. So as we move to accrediting the public health, you know, that's one of those avenues that also can be a lever or a tickler for it.
Fantastic.
Yes.
Were you going to say something? Sorry. I'm Martha Gold, and I'm a member of the Roundtable and chaired an IOM series of reports that took on some of the issues of buttressing the public health infrastructure. So Judy's question is really important, and George's answers to it is also very important. I guess I would ask to the group who've done a really marvelous job today of sort of telling us about, you know, great innovations in population health, sort of what the opportunities are here to make sure that there is a robust public health infrastructure in every community. If you believe that every community needs to have an appropriate medical care delivery system, it seems that one would also believe that every community deserves to have a strong public health infrastructure. You know, you can put things together in creative communities with good people to make things happen, but you don't have the legislative authority. And in fact, you don't have the same sort of skill base as should be in public health departments. So, you know, as you think about monies that are sort of fungible, coming back from reform, you know, paying physicians more, paying hospitals less, moving the money around, what I really would like to hear about is whether people have had strategies or opportunities to think about refurbishing the public health coffers and sort of political strategies that would make that happen.
Well, I've been thinking about this a lot. I'm a local public health director. And I think with our CCO global budget, we have mandatory memorandums of understanding with both the Mental Health Authority and the local public health authority. So in some of those CCOs that in the map I showed you, they've actually contracted with local public health to do specific population-based prevention. For instance, how is local public health going to get the background work that you need to change the conditions around tobacco, you know, regulations and who sells what and registries and outreach and enforcement. That's actually some places where the CCO is paying local public health to do that because they see, you know, what's their data look like, what's their top 10 morbidity, you know, indicators. So being at that table allows that conversation, and I could obviously go on, have a lot of energy around this, but let me just say there's a couple of things, and I think that that are in our favor to build that capacity that George was talking about, and one is accreditation. I mean, I think that accreditation is important. In a lot of ways, you know, but it also says this is what the contract I have with my community that I have to do. Where I think some of the challenges are is that we have to think more about issues around regionalization and who are our accreditation partners, particularly in some of the smaller jurisdictions and medium-sized jurisdictions. And I think once we, as a public health practice community, governmental public health, kind of get more facile, if you will, with the outcomes that are required and the processes that are required for accreditation, I'm really looking forward to the next stage of the conversation. Well, like, who's doing what here, you know, and how can that be funded most effectively? And I think in different parts of the country, that's where that conversation is leading. But one of the things that I always say to my academic partners, you know, is that you have to remember that governmental public health reports to electeds. So if I want to do something throughout the state of Oregon, I'm going to have to make sure that all the local boards of county commissioners who are either the Public Health Authority board or appoint people to it, they have to be on board on the changes that practice changes that we want to make. So that really requires a lot of sophistication in our understanding of how we message our public health goals and outcomes and what we're trying to achieve. And I think that sometimes most success comes when you have somebody else carrying the water for you, like when the hospital system says, I want to pay the public health community to do this, or when we're having these committees of how are we going to make sure the hospitals get their IRS community assessments done, and how do we do the Affordable Care Act assessments, and people are actually saying, oh my gosh, I didn't know your epidemiologist could do all that, well, you should do that for our community, but those dialogues need to happen, and I think that's part of the process of capacity building. I'll stop there because
Other comments from the audience or from the panel on that?
I would just reiterate that be better partners. Public health departments, it had been talked about as meta leadership before. I think it really boils down to having public health departments understand better how to partner with communities, but partner with business, partner with foundations, partner with non-health entities. There's a lot of talent, a lot of willingness, a lot of resource out there that health departments could help see the light in terms of what could be done to benefit the community in a lot of different ways within the realm of transportation, within the realm of environmental change, within the realm of education. All of these have tremendous health opportunities and health benefits, and it doesn't always have to be done with money. It doesn't always have to be done with a lot of legwork, other than sitting down and talking to these other non-health entities and helping them to understand how their decisions and the way they run business and the enterprises that they're involved in could better benefit health. So becoming much more facile at that, maybe even training to that, and populating public health departments to that end with the kind of people that would have that insight. MBAs in public health department, lawyers, economists, at least people with backgrounds and stronger backgrounds in communication, in business partnerships. Those kinds of talents in health departments could go way far in getting a lot more engagement around population health and making synergy happen, which is really what it's about. I don't think we're ever going to see a day where public health departments are going to be populated like hospitals. I wish, but not going to happen.
I've been doing a lot of thinking about how to bridge between healthcare and public health lately, and so I was doing some literature searching, and I found an article that said worlds apart, and I thought, oh, this is what I want to read about it, and it was from England. So we're not the only ones who are struggling with this, but I think it does get back to, I think, some of what you said, George, about leadership seeing this vision of how you can bridge these two worlds and finding some, common vision of population health, common goals, and just taking some next steps in how to do that together, which I think will strengthen public health and will strengthen healthcare and what it really needs to do. But so next question.
My name is Bob Griss. I work with the Institute of Social Medicine and Community Health. And my comment is really related to the very point that you're addressing now and that Martha raised. But she raised it as a public health infrastructure question. How do we politically create a public health infrastructure? And I think the problem is thinking of it as a public health infrastructure. I think we need a population health infrastructure. And we have only steps in that direction in the community health assessment requirement for those nonprofit hospitals. But I think we need to make more explicit, not how the public health system is going to try to salvage itself, but how we all have an investment in population health, which often means doing things differently. So much of what I heard today were examples of voluntary actions by different interest groups for people who share a common vision. And I guess it's better to work with people who share the common vision than to invite in people who are politically and financially opposed to that vision because they're profiting from the status quo, this fragmented system that we all bemoan while we benefit from, while we profit from it. And it seems to me that what's unique about this panel is that you represent different organizations within the health care continuum. And Josh's point about how to create a system which has an incentive to identify, to generate its creative ways of doing things differently so that the population health goals are fulfilled, because we all benefit from it. That's not just rhetoric. We need to demonstrate that it actually functions that way. So what I think we need to do is make more clear what political structures are interfering with the system functioning that way. And I don't think we're taking that on because it's politically challenging. So we talk to people who share our vision, and we try to be as creative as we can, whether it's from a FQHC point of view or from a, some public health agency. But Josh was speaking as the director of Department of Health. That bridges medical care and public health in terms of accountability. And I think that for various reasons that he didn't describe and that I don't know the answer to, there are unique things happening in Maryland and have been happening there which permit the kind of logic that he alluded to from developing. And I don't hear that happening in the other states. I hear some creative struggling with limited resources and whatever volunteers you can bring to the table. But I don't see enough focus on a structural population health requirement. And I'm looking for regulatory authority that would make that possible. I'm looking for, licensing standards for hospitals and other providers in the healthcare delivery system that would recognize that they won't be permitted to benefit from the status quo. We talk about the status quo as fee-for-service, as if that's the real problem, but I'm not sure that's really the problem. I think the problem is that we have a fragmented system where we don't all benefit from population health. And I want to relate that to this health equity business, because it's one thing to say we ought to have data driving our where dollars are allocated. And yeah, do we need new medical schools to train more doctors, or do we need them to be training nurse practitioners, or to open grocery stores in food deserts? I think we need to create an infrastructure, a population health infrastructure that puts all of those issues on the table and is driven by data around goals of reducing or eliminating health disparities. And I think we can get there. England was closer to it before the Conservatives took over, but I think we have an opportunity to start focusing on structure, and I think we'll get further with it. This is a unique panel because, yes, we're talking about medical care and public health in the same panel, but we're not talking about the leverage, the public policy leverage, which we really have in this system, where 60% of all the dollars in the healthcare system are public dollars. If you think of the public dollars, meaning, where the public employees are getting their health care from, where the private insurers who get a public subsidy for their, for their insurance that they provide to their employees, and of course for the federal programs and state and county programs. We got a lot of public leverage there. We're not using it.
So panelists, So where are some structural population health requirements that would be helpful to you, that would actually move you along further?
Well, I'm sorry that, I apologize. I mean, we have $1.9 billion resting on this. I mean, I think that's kind of all in the state of Oregon. And the CCO, Population Health, they're responsible for all of that together. So specific outcome measures are, our quality measures and our response, all of those measures are played out at that local level. And this is the law of the state. So I'm missing something here, but I think we're trying to get at what you're saying in the state of Oregon. We have legislation, we have bills, we have rules and regulations that says we're all in this together, and we're actually betting the farm on it, because we didn't get this money as an incentive. We have to earn it up to $1.9 billion. So, so there is that sense of that is, I think, why, we're not working just around the ACA model of hospital and health systems, but in the coordinated care organization I'm in, there's 3 counties and 7 hospitals and 4 systems and 4 payers, including Kaiser Permanente. So we're trying to look at a population in the most populous area of the state together, whether your insurer is Kaiser or Providence Insurance, whether you go to an FQHC or you go to one of the Legacy Systems hospitals. So I think we're trying to get at that. It's a journey. I think that, but we are carrying the money, and the structure is in statute. So, that's part of what we're trying to do. But again, we do feel that these have to be based on different areas of the epidemiology in the state. So I mentioned that number 9 cause of morbidity and mortality in my jurisdiction is liver disease. I got to do something about that across the spectrum. I got to get people to pay for stuff. I got to get needle exchange out there. I have to get public health policies around, how we sell alcohol and things like that. So I think you've nailed it, but I think this is what we're trying to do, and I think that a lot of what Janine's talked about is bringing it from, instead of starting with the legislature and the governor and all that stuff and bringing people to the table, starting with, not-for-profits in a region and bringing them up. But I think what I heard on the panel is the successful goals will be met when everybody's all in.
Very briefly, in California, we have the Strategic Growth Council. It was established 3 years ago. Is a perfect example of entities, including health and outside of health, transportation, education, commerce, all the business development, all of the different agencies in the state are required, mandated by law, to work together towards equity and health ends. And decision-making about health is embodied in a set of indicators that have been developed by what's called the Health in All Policies Task Force, that is a subgroup of the Strategic Growth Council, operates under the Office of the Governor and the Office of Health Equity. We do have a roadmap for what will create better health and health equity in the state, and that is evolving. It now needs to filter down so that localities also adopt that. But it's something that I hope we bring here to this Population Health Roundtable, because I think it's a really great example, and people from other sectors as well as health that can come and talk about what is contributing to health from their sectors, from the transportation, from the housing side, from the development side, from the economic development side. It's really quite a good, powerful model.
I think what you're asking for is what we need to do in this roundtable, is to begin to think about how to move towards that. So I see that we're kind of out of time, so I'm sorry that you don't get your question, but maybe you can grab one of the panelists at that. But meanwhile, I'd like you to ask to join me in thanking the panelists and speakers.